guys, and thanks so much for joining me for this video. In this video, I'm going to review Module 49, which talks about mood disorders, which include depressive disorders as well as bipolar disorders. Okay, so depressive disorders include major depressive disorder and persistent depressive disorder, and also something called seasonal affectiveness disorder. Okay, so with major depressive disorder, the person experiences, in the absence of drugs or any other medical condition, 2 or more weeks with 5 or more of the following symptoms, at least one of which must include either depressed mood or loss of interest or pleasure. Okay, so these symptoms might include difficulty with decision-making or concentration, feeling hopeless, poor self-esteem, having reduced energy levels, problems regulating sleep, or problems regulating appetite. With persistent depressive disorder, a person experiences a mildly depressed mood more often than not for at least 2 years, along with at least 2 other symptoms. And like I said, for some people, these depressive symptoms only develop during certain seasons. So, for example, during the winter time, when there's less sunlight and less good weather and things like that, seasonal depressive disorder can develop, and it often has to do with a dysregulation of the circadian rhythms, which is kind of our body's biological clock. And then we have bipolar disorder. So bipolar disorder is a disorder in which a person alternates between the hopelessness and lethargy that's characteristic of depression and the overexcited state of mania. And bipolar disorder was formerly known as manic depressive disorder. And when we talk about mania, essentially what we're referring to is a hyperactive, wildly optimistic state in which dangerously poor judgment is common. And mania can also present with what are called psychotic features. So that might include for example, visual or more common than not auditory hallucinations, and also false beliefs about the world or delusions. And mania, or stronger episodes of mania, are characteristic of what's known as bipolar 1. So there's 2 types of bipolar. Bipolar 1, which is marked by more persistent episodes of mania, often with psychotic features, and bipolar 2, which is where you're more likely to experience depressive episodes cycled with what's called hypomania, which is a manic state that isn't quite so severe. So bipolar disorder is much less common than major depressive disorder in terms of its incidence or how common it is. But it's also much more dysfunctional, particularly bipolar 1. And it is, in fact, a very potent predictor of suicide. So there has been a lot of attempts on the part of psychologists to develop various therapies and medications to effectively treat bipolar disorder. And also to manage suicidality in individuals with this disorder. Okay, so there are a number of theories of depression that are there are a number of findings related to depression that psychological theories have to explain. First and foremost, theories of depression have to explain the behavioral and cognitive changes that accompany depression. So what are some of the maladaptive actions that we often see on the part of individuals with depression? And what are some of the changes in thinking that often accompany depression? Theories also have to explain the fact that depression is very widespread and is in fact the number one complaint of individuals seeking assistance from a psychologist. We also have to explain why women's risk of major depression is nearly double that of men's risk for major depression. We also have to explain why most major depressive episodes end on their own. Stressful events related to work and marriage or close relationships often precede depression. And with each new generation, depression is becoming evident early and earlier in life and affecting more people. Right? So if we look at depression's developmental trajectory, one study found that among nearly 10,000 British teens and young adults, depressive symptoms increased during a 10-year period. So they followed the same people over a 10-year period, and they found that depressive symptoms increased, and often the first signs of depression appeared during the teen years between 12 and 14. And this was especially prominent among females. Okay, so what about the genetic influences of depression? So using aggregated data from studies of identical and fraternal twins, researchers estimated the heritability of bipolar disorder, schizophrenia, anorexia, major depressive disorder, and generalized anxiety disorder. And heritability was calculated by a formula that compared the extent of similarity among identical versus fraternal twins. Okay? And what they found is that risk increases if a family member has that disorder. And they estimated the heritability of major depression among twins at about 37%. And so essentially what they concluded is that many genes work together and produce interacting effects that increase risk for depression. Okay, so what happens in the brain when we experience major depression or bipolar depression? Well, first there is diminished brain activity that occurs during depression, and is also more active during manic periods. So other brain differences have not been found, right? So we see that brain activity slows during depression and reaches a peak period of activity during manic episodes. Neurotransmitter systems influence depressive and bipolar disorder, perhaps through a norepinephrine and serotonin gene, right? So we see that norepinephrine and serotonin levels rapidly decline during depressive episodes, and it's possible that this diminishing of neurotransmitters is due to a genetic component. And diets associated with inflammation and excessive amounts of alcohol often put you at risk for having a depressive episode. And also the left frontal lobe is considerably less active during periods of depression, which might explain some of the difficulties with planning, for example, and concentration that depressed patients experience. So if we look at brain scans, right? So one type of scan we can use is a PET scan, and that shows the brain's energy consumption, or it shows that the brain energy consumption rises and falls with the patient's emotional changes. Okay, so red areas show where the brain is using energy most rapidly. And PET scans have shown that during depressive episodes, there's slowed brain activity, less activity in the left frontal lobe, as I said, and also minimal amounts of norepinephrine and serotonin. Okay, so we see during a depressed episode, there is not very much activity, okay? Whereas in a manic episode, there are several different active or energy consumptive areas of the brain. Okay, and again, what we see is that there is a profound effect of nutrition. So people who eat a lot of vegetables, fish, and olive oil have a much lower risk of developing heart disease, stroke, cognitive decline as a result of aging, and also depression. And all of these things are associated with general inflammation, which can contribute to depression. And also alcohol is a very, very potent nervous system depressant. So alcohol is one of the most significant accelerators of a depressive state. So individuals who drink alcohol, particularly in excess, are most at risk for a depressive episode. Okay, so now let's talk about some of the social and cognitive changes that seem to develop in individuals with depression. So depressed people tend to view both themselves and the world in a profoundly negative light. And they tend to develop what's known as learned helplessness, which is the sense that if they were to change their behavior, that they would ultimately be unsuccessful at eliminating their depression. And that often coexists with self-defeating beliefs, self-focused negative rumination, self-blaming, and a generally pessimistic explanatory style. Right? So what are some theories that attempt to explain this? Well, the social cognitive perspective of depression basically explores how people's assumptions and expectations are going to influence their perceptions. So again, self-defeating beliefs and a negative explanatory style often contribute to the cycle of depression. And depression is often viewed as an ongoing cycle where stressful experiences are interpreted through negative beliefs, attributions, and memories, and that leads to negative moods and actions, which in turn fuel new stressful experiences. Okay, but let's look at that what I mean by negative explanatory style. Right? So this is an example of a stressful life event, right? Suppose you break up with your romantic partner. In interpreting that event, a depressed person is going to be more likely to make stable, global, and internal attributions in their explanation for that event. So for example, an example of a maladaptive stable attribution might be, I'll never get over this, right? Or I'll never stop experiencing the sadness and loneliness and despair that I feel because my partner is no longer here. An example of a global attribution. Without my partner, I can't seem to do anything right. right? So that's global because we're using words like anything or always and never, rather than recognizing that we might experience that in only a specific context, right? Internal is turning the blame in on oneself, so saying the breakup was all my fault. And as a result of these stable, global, and internal attributions of a stressful or negative life experience, we're going to experience depression. And we can contrast that with a more healthy explanatory style, which includes temporary, specific, and external attributions, right? So in interpreting one's breakup with a romantic partner, we might conclude, instead of saying, I'll never get over this, we would say, for example, I'm in a difficult situation right now, but I will get through this, right? And even simply stating that attribution might encourage you to seek out potential solutions, right? So maybe I can talk with some of my friends who have broken up with their significant others and see kind of what they say about the best ways to cope with it, right? So specific attributions, right? So a depressed person is going to say, without my partner, I can't do anything right. Whereas someone making a specific attribution might say, I miss my partner, right? But I also have great relationships with my friends and my family, and I can rely on them during this difficult time. An internal attribution characteristic of depression, again, is the breakup was all my fault, whereas an external attribution says, it takes two to make a relationship work, and it wasn't meant to be, right? So that is going to lead to successful coping during a stressful life event, as opposed to that experience of depression. Right? So again, after a negative experience, a depression-prone person may respond with a negative explanatory style, right? So let's suppose someone has a gene that makes them tend to have deficient amounts of serotonin and norepinephrine, and they've also had environmental experiences that make them more prone to experience depression. They are more likely to develop this negative explanatory style, and that is in turn going to perpetuate their depression. Right? So again, the vicious cycle of depressed thinking is that we have a stressful negative life event. In interpreting that event, we make internal and global attributions where we put the blame on ourselves. And that negative explanatory style and those attributions are going to contribute to depressed mood, okay? And that depressed mood is going to further perpetuate feelings of self-blame, feelings of low self-worth, etc. So what therapists do is they recognize this cycle and they work to help depressed people break out of it by changing their negative thinking, okay, turning their attention outward and engaging them in more pleasant and more adaptive coping behavior, right? So for example, a therapist simply pointing out that they tend to make global and internal attributions, right? And maybe challenging some of those attributions is one of the most important and most effective ways to treat depression. Okay, so this concludes my video on mood disorders. Certainly, if you have any questions, feel free to reach out, and I look forward to seeing you in my next video.